lying behind the stomach. It gets its blood supply from the splenic artery, from the left gastroepiploic artery, from the right gastroepiploic artery, and superior mesenteric artery is coming from just behind the neck of gallbladder, and from on the right side there will be superior mesenteric vein. If you see, this is common bile duct, retroduodenal portion, and here it lies in a groove behind the pancreas and enters into the duodenum, second part of duodenum. Here is the histology of the pancreas. If you remember, the pancreas is composed of lobules, and within the lobules there are acini. Acinar cells, they synthesize the enzymes, proteolytic enzymes, lipolytic enzymes, and the enzymes which digest carbohydrates as well. These are the smaller pancreatic ducts. They join to form main duct, and this is the pancreatic duct. And within the lobules lie islets of Langerhans, which contain beta cells in the center, alpha cells, delta cells, and the endocrine function of the pancreas is to secrete insulin by beta cells, glucagon by alpha cells, and delta cells they secrete somatostatin. Now, if you see from here, this is the main pancreatic duct, which opens along with the common bile duct. This is here in the intramural part of the duodenum is the common channel where common bile duct and pancreatic duct, they join together and open into the second part of duodenum at the ampulla of Vater. And this small duct is going at the accessory minor duodenal papilla. This is the duct of Santorini. This is duct of Wirsung, and this is Santorini. Now, today's topic is acute pancreatitis. Pancreatitis means it is inflammation of the pancreas. But contrary to the inflammation in rest of the body, here inflammation is not due to a sepsis, not due to infection. It is due to premature activation of the enzymes of the pancreas, which start autodigestion of the pancreatic parenchyma and incite an inflammatory reaction within the pancreas, and then inflammatory cells, they arise, they release cytokines, and these cytokines IL-1, IL-6, tumor necrosis factor, and there are a lot of cytokines, platelet activating factors, prostaglandins, they all contribute to the inflammatory response. When the response is localized within the pancreas, it leads to just, you have fresh knowledge from pathology, inflammatory response. There is vasodilation of the vessels, and there is increased capillary permeability that leads to edema of the tissue where the inflammation is going on. This inflammation, when it is localized, it leads to edema of the pancreas. And if the cytokine storm gets entry into the bloodstream, then it can go anywhere in the body and give rise to systemic complications. There will be increased capillary permeability in any part of the body and can lead to complication. Number two, when there is edema of the pancreas, there is increased capillary permeability of within the vessels of around the pancreas. There is fluid sequestration into the third space that is known as third spacing, and that leads to hypovolemia. Initially, there is inflammation in the pancreas that leads to hypovolemia, cytokine storm involving many parts of the body, and this hypovolemia with loss of the extracellular fluid, extravascular interstitial fluid into the third space would lead to hypovolemic shock and all the complications which are related to hypovolemic shock. That may be renal failure, that may be decreased permeability, mucous membrane damage of the GI tract, and many more. Next, we come on to all these. Pancreatitis can be divided into acute and chronic. Here we are talking of acute pancreatitis, which is presents with there is auto premature activation of the pancreatic enzymes that leads to abdominal pain. The enzymes get entry into the bloodstream. From the bloodstream, it can go to the urine. And the main, it is acute pancreatitis is a sudden, severe onset of abdominal pain due to premature activation of the proteolytic enzymes. What can cause this pancreatitis? Anything can cause pancreatitis, which leads to activation of the pancreatic enzymes. Usually, there are two most common causes. In our setting, it is the gallstones. In Western world, it is alcohol. The percentage reverses. In our setting, it is 50 to 70%, 5% cases, it is gallstones, and 25% is the alcoholism. But in Western world, it is other way. Alcoholism is the number one cause and gallstones are the number two. And the rest of the percentage is covered by many causes. You can memorize it by just eye get smashed. I for idiopathic, gallstones I've already, ethanol is alcohol, trauma, blunt trauma, abdomen, patient will give X3, steroids, patient will be taking steroids for bronchial asthma, for rheumatoid arthritis, many autoimmune disorders may be steroids. Mumps or some malignancy can trigger pancreatitis, autoimmune diseases, scorpion stings, snake bites, hypercalcemia, hypertriglyceridemia, and you can say hyperparathyroidism is one of the causes. ERCP, later see ERCP is one of the investigation for acute pancreatitis, but ERCP sometimes can give rise to pancreatitis, can initiate pancreatitis. And drugs like azathioprine, steroids, anti-epileptics, they can cause pancreatitis. So two major causes are biliary calculi and alcohol. This is briefly, this is the pathophysiology. Any cause will ultimately lead to activated enzymes. Once there will be a sinner cell injury, enzymes would be activated, and there will be interstitial inflammation and edema, proteolysis, autodigestion of the pancreatic tissue, parenchymal tissue, fat necrosis. The lipases and phospholipase, they split the fats into free fatty acids and glycerol, and free fatty acids, they combine with the calcium in the circulation of in the tissues to form the fat that is known as sponification, and elastase leads to hemorrhage. And all these mechanisms, all these changes, activated enzymes will lead to these sort of pathological changes, and all these lead to acute pancreatitis. And now the pancreas is swollen, edematous, friable, and now what would happen? This is the pathophysiology. Now, acute pancreatitis would resolve, either it would resolve pancreas, if it is edematous, with some maneuvers, or luckily, the pancreas would start healing. Number two, pancreas can become necrosed. It may be a focal necrosis, or whole of the pancreas may get necrosed. This we will discuss later on. Number three, there may be hemorrhage into the, that is known as hemorrhagic pancreatitis. That is very severe form of pancreatitis. So now, what we have to do, the patient, say for example, I give a scenario, 60 years old female who is a known patient of gallstones presents in the emergency ward with sudden severe abdominal pain in the upper abdomen, and she is collapsed. She has come in shock. All other investigations we will discuss later on what is going to. On CT scan abdomen, pancreas is swollen, edematous, and there is necrotic area. So patient can present in any way. We have to diagnose. Number one is we have to diagnose, is it pancreatitis or something else? What comes in the differential diagnosis? And then we will reach a diagnosis by means of history, physical examination, and then we have to rationalize the investigation. It is not that we start writing all the investigation which can be done for a single patient. We have to rationalize what investigation would be more relevant and that should be done. So for the diagnosis, we have to take history and physical examination first. History taking, the purpose of history taking would be to reach a diagnosis. What is the cause of pain? Then history is taken to what is the cause of pancreatitis, and then history is taken to ascertain is there any complication which has developed or not. So abdominal pain in pancreatitis, mnemonic is Socrates. You can take history of any abdominal pain or any pain with this mnemonic. Site in pancreatic pain, it is diffuse upper abdominal pain, which is sudden, boring pain, or maybe severe. It radiates through to the back, associated with nausea, vomiting, and dyspnea. And pain is sudden in onset and escalates in intensity and reaches its peak within 10 to 20 minutes. And it is aggravated by breathing, सांस लेने से increased. And if there is a typical posture of the patient with pancreatitis, he leans forward. Depending upon the severity, patient may present in shock. And then history is taken to uncover the cause of pancreatitis. What has caused? The most common cause, patient may give a history that he is a known patient of gallstones. Patient may give a history that he is a regular drinker. Patient may give history that in the recent past, within a 5-7 days, he had trauma in the abdomen. He is taking medicine, treatment history, medical history. May you can ask for any drugs, steroids and drugs for any other condition. Has he undergone ERCP? Is he known patient of lipid hyperlipidemia, triglyceridemia, any snake bite? These are the causes which should be uncovered. And then history is taken. सांस तो नहीं चढ़ता, यूरिन आउटपुट ठीक है, हार्ट बीट के बारे में पूछ सकते हैं, टेटनी के बारे में, हाथ पांव मुड़ तो नहीं जाता, शुगर तो नहीं, कंफ्यूजन, drowsiness, anything. And mostly local complications develop silently and there is usually no symptoms. But pancreatic abscess can present with high-grade fever. If patient had pancreatitis and now he is having high-grade fever, pancreatic abscess should be in the mind. So patient may present with a swelling in the epigastrium. On physical examination, vital signs, elevation of blood, body temperature may or may not be there. It is often in acute pancreatitis. No, it is maybe normal, maybe subnormal, maybe hyperthermia. On abdominal examination is always inspection, palpation, percussion, and auscultation. On inspection, abdomen is distended, colon sign will be present, greater sign we show you. On palpation, there is rigidity and tenderness, and liver may be aligned. This is colon sign. There is fluid discoloration around the umbilicus, and this is in the flank. This is greater sign. If we percuss, if there is ascites, flanks will be dull and shifting may be positive. And auscultation of the abdomen, there may be absent bowel sounds or abdominal bruit. Lungs should be auscultated because there may be basal atelectasis, may be pleural effusion due to pancreatitis. So the breath sounds would be decreased on the lung basis. As pancreatic pain is in the upper abdomen, anything which is in the upper abdomen can mimic the findings, symptomatology of pancreatitis, like myocardial infarction, basal atelectasis, basal pleurisy, pneumonia, cholecystitis, even appendicitis, abdominal aortic aneurysm rupture and intestinal ischemia can present with same perforated esophageal ulcer, can present just like appendicitis. And when we rationalize the investigations, the purpose is to diagnose pancreatitis and number two, to rule out the differential diagnosis. So if there is mild acute pain, cholecystitis, peptic ulcer, myocardial infarction, appendicitis, and if there is severe fecal perforated colon or even perforated DU, ruptured abdominal aortic aneurysm, ectopic pregnancy, massive bowel infarction, they will come under consideration and investigation would be able to rule out these causes. So what investigation can be done for acute pancreatitis? सबसे पहले तो ये होगा कि the enzymes which are released and they cause digestion of the pancreatic parenchyma, they are released into the circulation and they can be checked in the bloodstream. Serum amylase 3 times raised is indicative or more than 1,000 international units per ml. The level is at its peak within first 24 hours, and then it starts decreasing, and by 72 to 96 hours, the levels are near to normal. So if the patient comes late, serum amylase might not be very helpful. Serum lipase has a longer half-life, and it would give a more useful information if the patient comes late. It is more sensitive and specific than a mild. Other tests, CBC, LFTs, you can see blood sugar and serum calcium. And these tests would give an indication about some clue to the severity of the disease. Not severity of the disease, rather it would give us a clue towards the management. And number two, it would let us uh, mark the severity of the disease. We discussed immediately. Imaging, that means radiological investigations, they are to clarify the diagnosis. They are to determine the cause. They are to detect complication. And they are to assess the severity of pancreatitis. So the purpose is to diagnose the, is it pancreatitis? What is causing the pancreatitis? Has it complications? And what is the severity of it? These are the three questions. One, is it pancreatitis? What is the cause? How severe it is? So investigation, first investigation is non-invasive investigation, ultrasonography. Ultrasonography is showing this is head, body, and this is the tail, and this is swollen. This is ultrasonography. Ultrasonography पे शायद diagnosis न बने, but it rules out other differential diagnoses like CBD stone, polycystitis, and this is ERCP. It is not. If ERCP is endoscopic, a retrograde cholangiopancreatography. This is radiological investigation to outline the common bile duct, which is not shown here, and pancreatic duct. This is the normal pancreatic duct. You can see the diameter caliber of the pancreatic. It is a thin duct. There is no dilatation, nothing, no filling defect. But here, if you can see, there is a filling defect. This is another filling defect. And upstream, the pancreatic duct is dilated and tortuous. That means this obstruction has led to proximal dilatation, distal dilatation. And here it is very much dilated pancreatic duct. And this is the scope that has come through the stomach and duodenum. It has cannulated the ampulla vater, and dye has been injected into the pancreatic duct. This is ERCP. And this is diagnostic, and it can lead to can be therapeutic if we do sphincterotomy by this endoscopic sphincterotomy, and with the help of, just like this is catheter passing into, with the help of balloon, we can extract these stones. We can extract these stones to relieve the obstruction, and the patient would be very much relieved. And this is plain X-ray abdomen. There is sentinel loop in pancreatitis. This is colon cutoff sign. And then The gold standard investigation in acute pancreatitis is CT scan. This is normal CT scan. एक सेकंड में अभी sorry. This is normal CT scan of the abdomen, and here you can see beautifully the normal anatomy which was initially we saw on the photograph. This is the vertebral body at the level of pancreas. This is the pancreas. This would be the head, neck. This is the neck rather. Here would be head within the duodenal sea, and this is the body and tail going to the hilum of the spleen. This is stomach in front of the pancreas, liver, and this is the gallbladder. This is vena cava, aorta, and this is the portal vein. This is splenic vein entering into the portal vein, and from this side, superior mesenteric vein would be coming. And this is CT scan in case of pancreatitis. Just here the pancreas was like this. And here it is like this. It is swollen. The texture has changed. These are the kidneys. Now, morphologically, this is revised in Atlanta classification. There are two varieties. In one variety, the pancreas is just swollen. In the second variety, pancreas has undergone necrosis. The inflammatory response has gone so much to cause death of the tissue. So that is necrosis. It can be of the parenchyma or peripancreatic necrosis. Pancreas के इर्द गिर्द जो फैट है वो भी नेक्रोज हो जाती है. And third variety is combined type. दोनों पेरेंकाइमा भी नेक्रोज हो गया और पेरीपेंक्रियाटिक फैट भी नेक्रोज हो गया. This is necrotype. When there is necrosis, and how it would look like. And for these cases, CT scan is the investigation of choice. In interstitial edematous pancreatitis, pancreas is enlarged. And with the help, when we give contrast material, the pancreatic tissue takes up the contrast. This is known as enhancement on contrast. There is peripancreatic fat stranding. This is inflammatory response, fluid collection within the fat, and it appears like this. And this edematous pancreatitis, usually it is of milder variety, and it recovers within a few 1 week or 2 weeks. But if it gets worse, it can convert into necrotizing pancreatitis. Here, mostly the pancreatitis is of this variety. But 5 to 10% cases, it is severe and it leads to necrosis. How can we diagnose necrosis on CT scan? If you see, this CT is known as early SECT. SECT means contrast enhanced CT scan. It is a CT scan with contrast. Contrast enhanced CT scan, when we give this contrast IV, the pancreas, which is normal, would be enhanced, show enhancement, because the blood vessels will take up the contrast and would be enhanced, but the dead tissue will not take up the contrast, and it would appear as non-enhanced lesion. And the necrosis would appear as non-enhanced lesion. So here you should see, just like this is the here is contrast and it appears white. The pancreatic tissue here, it appears as relatively white. This is the pancreatic splenic vein. It contains the contrast, but here it does not take up the contrast. So it appears hypodense, just like bile containing gallbladder. Air appears as black. This is duodenum and this is the stomach. This we will come later on. And now how to assess how severe the pancreatitis is. We usually use Ranson's score. There is Glasgow score, there is Apache, and there are many other systems to score the severity. But usually it is the Ranson. We in practice we have the investigations to. And mnemonic is legal C hops. Legal. This is overprinted. Leukocytosis, L for leukocytosis, more than 16,000. E for raised AST. G for glucose. A for age. And L for LDH. These are the 5 investigations which are done at the time of admission. And during next 48 hours, C hops, C for calcium, H for hematocrit fall, oxygen, PO2, B base deficit, B for bun rise more than blood urea nitrogen rise more than 5, and this is S for sequestration of fluid more than 6 liters. If among these 6 and 5, 11, there are 3 or more factors are present, we label it as severe, and this has the impact on the management, treatment of pancreatitis. This is Glasgow. We are not. How we are going to manage patient? Now we have taken the history, physical examination, investigated, and we have reached a conclusion that this patient is suffering from acute pancreatitis on the basis of history and serum amylase. We have reached a conclusion this patient is having acute pancreatitis. With the help of Ranson criteria, we have divided it into mild variety or severe variety, and that would dictate our treatment. Mild acute pancreatitis. In acute pancreatitis, what is the problem with the patient? Patient has got severe pain in the upper abdomen. Patient is having nausea and vomiting. Patient is in hypovolemia due to extravasation of the fluid into third space. So these are 3 problems have to be addressed in mild variety. Nil by mouth would decrease vomiting, and even if vomiting is not settled, we can give antiemetics, and even if that is not settled, we can put nasogastric tube to decompress the stomach so that vomiting is not there. But to keep the patient nail by mouth is not evidence-based. As soon as the patient doesn't have nausea or vomiting, we should start oral fluids or oral feed. The first problem actually is the pain. We have to relieve the pain. Patient is in agony. We have to relieve the pain by narcotic analgesia. But narcotic analgesia does cause spasm of the sphincter of Oddi at the ampulla vator. And if that gets obstruction, so we know gallstones or anything in the pancreatic or common bile duct, common channel, any obstruction can lead to blockage to the pancreatic juice and premature activation of the proteolytic enzymes that can, so by giving narcotic analgesia, we can induce that sort of situation. So The spasm of the sphincter of Fodai caused by this narcotic analgesia should be balanced by giving antispasmodic drugs like Buscopan or fluoroglucinol. Any antispasmodic drug can be given combined with this narcotic analgesia. And the third problem is hypovolemia induced by inflammatory response, increased capillary permeability. We should resuscitate the patient with IV fluids, and that is the mainstay of treatment. And if the cause is whatever you diagnose the cause, gallstones, alcoholism, or any other rare cause, we have to treat the cause. That otherwise the patient would have recurrent attacks of acute pancreatitis and leading to chronic variety of pancreatitis. There is no role of antibiotics. There is no role of any other. We are using somatostatin analogs to decrease the secretions of pancreas, but there is evidence says there is no role of any drug. The treatment is only this. Either the pancreatitis was settle or it would go on to the severe pancreatitis. And the severe cases, they have to be treated in high dependency unit. Patient should be admitted, given oxygen, analgesia, the treatment which we have already, aggressive fluid rehydration, and then monitor whether the fluid replacement has stabilized the patient, monitor the vital signs, hematological and biochemical parameters. If the patient keeps on vomiting, nasogastric drainage, antibiotics. Yes, antibiotics. Here they can be given for the prophylaxis because severe pancreatitis would have pancreatic necrosis, and that necrosis you in the beginning it is sterile, but later on it can become infected, and that is a catastrophe and very severe type of complication. To prophylactic antibiotics should be given in such severe acute pancreatitis. And number two, these patients might have element of cholangitis, so we have to give antibiotics. CT scan should be done to assess the complications. Diagnosis has already been made, and CT scan is done to check for the complications. ERCP within 72 hours should be done, and if there is some organ failure, it can lead to cardiorespiratory failure, it can lead to renal failure, it can lead to DIC, it can lead to GI failure. Supportive treatment has to be given for whatever the organ is involved. If cardiac inotropic support, respiratory ARDS हो गया तो हम उसे रेस्पिरेटरी वेंटिलेटर पे डालना पड़ सकता है, ऑक्सीजन देनी पड़ सकती है, रीनल फेलमेंट डायलिसिस देनी है, and patient would be needing nutritional support if he or she is nil per for more than 5 days. What complications can arise? We will briefly know. Systemic complications, they usually occur within the first week, and they will resolve, and they do not need any surgical treatment. They are managed by medical and intensive care people. Cardiovascular, patient may go into shock and arrhythmias, pulmonary ARDS, renal failure, hematological कॉम्प्लिकेशन DIC हो सकती है, GI ट्रैक में ILS जैसे सेंटिनल लूप हमने पढ़ा था, मेटाबॉलिक कॉम्प्लिकेशन में हाइपोकैल्सीमिया, हाइपरग्लाइसीमिया, हाइपरलिपिडेमिया हो सकता है, पेशेंट may have visual disturbances, may be confused, may go into coma, and patient may have arthralgia due to deposits of fat necrosis within the joints. And locally, patient may have fluid collection around the pancreas. That is known as acute peripancreatic fluid collection. And if it does not resolve after 4 weeks, it is known as pseudocyst. And if it is necrosed, it surrounded by fluid, it is known as acute necrotic collaction. And if it gets and walled off more than 4 weeks, it would be walled off necrosis. But once it gets infected, it is infected pancreatic necrosis, pancreatic abscess, and pseudocyst. Pseudocyst is very commonly asked question. So pseudocyst can be approached. Usually it lies behind the stomach and it anterior wall of the stomach उसको इंसाइज किया है, उसके थ्रू पोस्टीरियर वॉल को इंसाइज किया है और सिस्ट की वॉल को स्टमक की पोस्टीरियर वॉल के साथ कंटिन्यूस रनिंग सूचर के साथ अनेस्टमोस कर दिया है. दिस इज सिस्टोगैस्ट्रोस्टमी. So there is question, sir, it is kindly share these slides in our class group. This will ensure अगर आप सुन रहे हैं क्वेश्चन नहीं है, सजेशन है, तो डिफिकल्ट टू, मुझे नहीं आइडिया कि जी आपका ग्रुप है. अगर ग्रुप है तो आई एम नॉट एडेड इनटू इट. और अगर मुझे ऐड कर लिया जाए तो आई वुड शेयर दीज होल लेक्चर ग्रुप में डाल दूंगा. आप किसी भी वक्त पढ़ सकते हैं. कोई क्वेश्चन इसके बारे में हो तो आई एम हियर, और अगर बाद में भी हो तो इवन देन you can message in the group or whatsoever. So अगर ग्रुप, आई डोंट थिंक कि मुझे एक सेकंड, फाइनल ईयर पिछले साल तो आई वाज एडेड, इस साल अभी तक तो मैं एडेड नहीं हूँ. तो आई वुड रिक्वेस्ट टुडे अपने, आप स्टूडेंट्स एडमिन हैं तो मुझे ऐड कर लें. नंबर मेरा रेस, मुझे नहीं पता, आप मेरा ले सकते हैं. फाइनल ईयर की क्लास जो वार्ड में आती है वो मेरे से लेके तो वो ले सकते हैं. तो मैं से जो वार्ड नंबर 5 में क्लास आती है फाइनल ईयर की, तो वो मेरे से मेरा नंबर लेके, आप लोग ही मेरा ख्याल एडमिन होंगे तो मेरा नंबर उसमें ऐड कर दीजिएगा, जस्ट लाइक बाकी लोग जो लेक्चर लेते हैं उनकी तरह. तो मैं ये लेक्चर, और कल क्रोनिक पैंक्रेटाइटिस का लेक्चर होगा तो आई विल ये वो भी मैं शेयर कर दूंगा, ये भी शेयर कर दूंगा. नंबर आप मेरे से ले लीजिएगा. Any other? So I think time is over. Thank you very much for डिफरेंशियल डायग्नोसिस बता दें. डिफरेंशियल डायग्नोसिस की मैंने एक स्लाइड वो दोबारा दिखा देता हूँ. एनी डिजीज, दिस इज द acute cholecystitis, peptic ulcer disease, MI, appendicitis, high-lying appendix, perforated DU or perforated colon, ruptured ectopic pregnancy, and aortic aneurysm. Massive bowel ischemia of the intestine. They all can mimic. And one is not basal pleurisy in the region right side, left side, that can mimic pancreatitis. So any pathology in the upper abdomen, right hypochondrium, epigastrium, and left hypochondrium can lead to symptoms just like pancreatitis. Okay, thank you very much.